Last.
Good afternoon. I'm Dr. Nidhi, additional professor, RML Analyst, Lucknow. I will be discussing the case of a 19-year-old female with a history of intermittent abdominal pain, hypertension, palpitation, and elevated blood pressure. Adrenalectomy was performed and sent for histopathological evaluation in January 2022. We received the right adrenalectomy specimen with a weight of 38 grams and size of 7.5 by 5 by 4.5 centimeters. On gross evaluation, it was well circumscribed and with the tan brown appearance. On microscopic picture, we can see the tumor is in the medullary portion of the adrenal and pushing the adrenal cortical tissue towards the periphery. On the further higher power view, it was the appearance was valve with the well-developed vasculature. On the further higher power view, the cells were polygonal in shape with moderate to abundant cytoplasm, eosinophilic cytoplasm, and at focal area there were pleomorphic nuclei. Mitosis was very scant. So the histopathological diagnosis was rendered as adrenal pheochromocytoma. So according to WHO classification, with the this type of morphology, we had with the differential of pheochromocytoma, adrenal cortical carcinoma, and renal cell carcinoma. So for this, we performed the immunohistochemical panel for synaptophysin, chromogranin S100, inhibin, HMB45, and PAX8. So the tumor was beautifully positive for synaptophysin and chromogranin. So the final diagnosis, other markers were negative. So the final diagnosis was given as adrenal pheochromocytoma. For the risk stratification, we performed the pheochromocytoma of the adrenal gland scaled score, that is PAS scoring. So according to this score, the peri-adrenal adipose tissue, more than 3 mitosis, atypical mitosis, necrosis, cellular spindling, nuclear pleomorphism, cellular monotony, and large cellness or diffuse growth, as well as with high cellularity. 2+ score is given in capsular and vascular invasion with hyperchromesia. Score 1+ is given. So the total score of 4 is concerning for malignancy. So in the current case, there was marked pleomorphism. The PAS score 2 was given. Mitosis was less than 10 high power field. So the score was given as 2. The PAS score more than 4 is likely malignant, but the limitation of PAS scoring is the pheochromocytoma histopathology features, including the cellularity, cellular pleomorphism, and monotony, no prognostic value. This is applicable only for the pheochromocytomas, and the other histological characteristics like other influencing factors like gene mutation, tumor characteristics, and clinical characteristics of the patients were ignored. In addition, there are too many histological features, inter and intra-observer variability is present. So, according to the 2017 endocrine organ, WHO 2017, the term benign and malignant has been replaced by the term metastatic and non-metastatic, and the GAP scoring is introduced. So, according to the GAP parameters, in addition to the histopathological parameters, Ki67 labeling index is introduced, as well as the catecholamine secretion. So, in the current case, the pattern was gel balance, so the score 0 was given. The cellularity was moderate, so score 1 was given. And the Ki labeling index, Ki67 was 2 to 3%, so score 1 was given. So the patient was significantly secreting the normetanephrine levels, urinary normetanephrine levels were significantly high. So catecholamine level was given, score was given as 1. So total score was given as 3. That falls into the category of moderately differentiated. So for the score, risk stratification. So for the risk stratification, the score 0 to 2 is well differentiated, and the 5-year survival is 100%, and the score 7 to 10, that is poorly differentiated, the 5-year survival is 22.4%. So PAS or GAP scoring. Then in 2017, there came the modified GAP scoring system, and in 2019, the COP scoring system has came. That is the composite pheochromocytoma paraganglioma prognostic scoring system. And another is the AXIS score that is came into 2018, that consisted of age, tumor size, extra-adenal location, and the secretory type of the tumor. So for the modified gap scoring, the pseudorosettes, the comedotype necrosis, the vascular invasion, the Ki-67 labeling index that is more than 1%, and catecholamine type and SDHB stain in IHC negativity is taken into account, and the score more than 3 is considered to be metastatic tumor. So we performed SDHB IHC. So we can see in this microscopic picture the internal control, that is the endothelial cells, has beautifully positive for the SDHB, that retain the SDHB, but the neoplastic cells has lost the SDHB staining. So, and in the lower portion, we have presented the other case, that is SDHB retained. So SDHB, loss of SDHB is seen in about 15% of pheochromocytomas and paraganglioma, 3% of GIST, less than 1% of renal cell carcinoma, and less than 1% of pituitary adenomas. So in the modified gap scoring, the pseudorosette was not present, comedonecrosis was not present, Ki-67 was 2 to 3%, that was score 2. Capsular and vascular invasion was not present, and catecholamine was 2, and SDHB negative staining, that is 2 scoring. So total score was given as 5. So for the COP scoring, focal or confluent necrosis was considered, PS100 staining loss is seen, vascular invasion, SDHB loss, and tumor size more than 7 is considered. So for COP scoring, we reviewed our S100 stain slides, and there was loss of S100 in the sustentacular cells. So score 2 was given. SDHB loss was given as score 1. And tumor size was more than 7 centimeters, that was score 1. So the total COP score was given as score 4. So for different predicting system with their prognostic parameters, so pass score was 2, gap score was 3, modified gap was 5, and COP score was 4. So the according to the European Society of Endocrinology clinical practice guideline for long-term follow-up, the patient operated for pheochromocytoma or paraganglioma, there is no single clinical, biochemical, or histopathological feature that can distinguish malignant from benign PPGS. The multi-parameter pass score and the reproducibility of the gap score it requires further validation. A metastasis is defined as the presence of chromaffin tissue in location where normally no chromaffin tissue is expected. So another paper in the published in the Cancers, the value of histological algorithm to predict the malignancy potential of pheochromocytoma and abdominal paraganglioma, meta-analysis, and the systemic review. According to the authors, they have represented the schematic overview of the pass scoring system and the gap scoring system, and they noted the green square as the benign cases and the orange square as the malignant cases. So the left-hand side of the both the algorithm shows the benign cases and the less than 4 scoring system and score, and in the gap score, that left-hand side is the less than 3, that are the benign cases. So in the both algorithm, they show the excellent sensitivity but the reduced specificity towards the malignant cases. As we can see in the more than 4 score, we can see the green squares also, and in this gap scoring there is also the green square. So these analyses indicate that low pass and low gap or scores almost always are associated with the benign clinical course. So another study, another paper by the that is the predicting metastatic potential in pheochromocytoma and paraganglioma, a comparison of pass and gap scoring system. According to this paper, they found that gap performed significantly better than pass in predicting the metastatic potential. The poorly differentiated range was associated with better outcome than a well-differentiated score, and the most effective for the pass and gap are the most effective for negative predictive value of a low score. So a rule-out strategy has typically been utilized for both pass and gap, as low scores in both systems demonstrate negative predictive value, but higher scores have low specificity for malignant disease. with an advantage over the gap over the pass scoring system. Another paper in the American Journal of Cancer Research, the system of metastatic potential prediction in pheochromocytoma and paraganglioma in 2020. It says that the accuracy rate of metastatic prediction results that is 66% in pass, in gap 69%, and MGAP that is 53%. But the accuracy rate of non-metastatic prediction that is 100% in pass, 96% in gap, and 91% in MGAP system. So the scoring system have not been validated in multi-center clinical trials and have not been widely accepted by the clinicians. So in pass score, 12 parameters are utilized, low specificity, only pathological, and in SS, 4 parameters, it has worst sensitivity and lowest metastatic prediction accuracy, only clinical parameters have been used. So this is the TNM staging of the tumor. T1, pheochromocytoma, less than 5 centimeter in greatest dimension, no extraadrenal invasion. T2, pheochromocytoma, 5 centimeter or more than in greatest dimension with or functional paraganglioma with no extraadrenal invasion, and T3, tumor of any size with invasion into the surrounding tissue. So the learning points are, from the pathological point of view, benign versus malignant has been replaced with the non-metastatic versus metastatic for the risk stratification. Pass scoring has been replaced with the gap scoring or the modified gap scoring, and TNM staging should be given, and the biochemical test recommended to rule out the catecholamine secreting tumors. Thank you for the discussion.
Thank you, Dr. Nidhi, for nice presentation. And this case is open to the floor for discussion. Any query? Yes, sir. Krishnani, sir.
So what is the present recommendation? I think the present recommendation is that you keep on doing, and they are saying that don't do it. Scoring, they have said there is no validity. So presently in 2022 classification, WHO Blue Book, they said, they have still said that don't do scoring system. No scoring system is good or perfect or giving any good information. See, if you see the non-metastatic potential, it is giving 100%. Rest other things, if you say the metastatic potential, hardly 60%, 50%. So ultimately, it has got no benefit. So that is why they have said that don't do a scoring system in adrenal pheochromocytoma. But if you want, you can just note it down. That's all.
Thank you, sir.
Any other comments? Yes, ma'am.
So I would like to ask the surgeon, how many of this likely report so many cases? Over your experience that you find any metastasis over time. As pathologists, we keep on doing these scores.
So I never do a scoring system PAs. If we do it, 90% of cases are 0 to 1.
Yes, sir.
So it hardly makes any difference till now. And we have never seen any metastasis till now.
Thank you, sir. And thank you, ma'am, for asking this question. Actually, we not only the scoring, we see the entire clinical presentation of the patient and the tumor itself, whether it is extensive large tumor and surrounding structure, or if there is R0 resection is there or not. All these things we matter during the surgical, and during the follow-up we find out if there is any metastasis. And in the tumor which we have find out the metastasis, mostly it was a large tumor, and not the scoring, we have not correlated with the scoring. One publication is from our department that they have correlated, but that was found that it is not very much correlating with the metastasis, although we have checked the pass scoring system.
Yes.
Yes, sir. Thank you, sir.
Like in this patient, in this case, it was SDHB negative, means it was familial type.
Yeah.
So even at times we don't know it is multiple or it's a metastasis or the multiple that can happen. Even we cannot say whether this is metastasis or not metastasis. So even that problem is even not solved many times. Many times we say this is a lymph node completely replacing, but whether it is a lymph node or the paraganglia, we don't know.
Yes.
So in familial cases, even difficult.
Yeah, we have to
document.
follow and just taking out the tumor, and finally you will be decide whether it is metastatic or it is another paraganglioma. It is up to your report. We will follow accordingly. Any other comments?
So the next point is that if
Yeah.
age is less, like this 19 year,
Yeah.
so we should go for VHL, familial,
Yeah, familial
SDSP, all these things should be taken care of first of all.
Yeah, in young patients, we have to follow closely and find out, and also this genetic testing is required. Bhatia sir, any comment for